Raipur Obstetric Gynec Society and the Society of Fetal Medicine, I welcome our most respected faculty and our guests to this meeting. First of all, I would like to welcome Dr. Ashok Khurana sir, who makes a very, very great effort to make each of our meetings unique and interesting. And he really gives so much of effort to that. So welcome, Khurana sir. I hope we have 5 more to go and we will make each one more interesting. I welcome Ratnapuri madam, who has been present in all our meetings so far. So welcome Dr. Ratnapuri ma'am, Dr. TLN Praveen sir, welcome sir. Dr. Krishna Gopal, who has also been present at all our meetings, Dr. Aparna, who has been present in almost all meetings, and Dr. Vijay sir, welcome to this meeting. This is your first visit in Raipur, though it is virtual. So I welcome all of you, and to introduce the subject, I would like to say that we are going to talk about non-invasive prenatal testing. Why, when, and what next? So non-invasive prenatal testing, once upon a time, was something that was out of reach of the common person. When it was 25,000, maybe 35,000, but now the costs have come down. Now is the question that, are we going to do NIPT or are we going to go with the combined screen, which is the NT scan and the dual marker and the PE screen? So there are a lot of questions: when to do NIPT, when not to do NIPT, what to do after a positive test. To address all these questions, this time, this is a question answer session where all the experts will be answering questions that Khurana sir has specially cooked for them. And if in spite of hearing all the answers, you still have questions or some cases, you can put them in the chat box. With this, I hand over to Khurana sir. Welcome, sir.
Thank you. Thank you very much. It's always special to actually be here when we discuss the essentials of clinical fetal medicine series, also co-hosted by the Raipur Obs and Gynae Society. When we started this, we thought we'd have some formal talks, etc., some case discussions. And as we've evolved, we realized that when we have our webinars otherwise, we do end up with having to very, very frequently have the same repeat questions. And we reply to those, but we never get all the right answers. And a lot of our attendees seem to ask the same question. So what I did today was to change this whole system and make it purely, not as a case-based panel discussion, but as a panel discussion where I'm going to ask the panel the same question that you all ask us again and again. And I've requested them to give workable answers, not something out of a book, not something out of research papers, not something from a super expert panel that doesn't apply to a country and varied heterogeneous population such as ours, but straightforward everyday answers. And let me start by a brief history of the origins of current fetal medicine. We used to look for 2 things. The first was to look at what can we do with spina bifida, and the second was what can we do with Down syndrome. We started our whole story with spina bifida in the 1970s, early 80s, where we did a dating scan at 14 weeks, which was called the level 1 scan, and then a maternal serum alpha fetoprotein, and the ones that had a high maternal serum alpha fetoprotein would then be looked at a level 2 scan, which was done at 16 weeks. And as time evolved, we realized that you don't have to look just for open neural tube defects, but you have to look for full anomalies as well. While we were looking at maternal serum alpha fetoprotein, we did realize in the 80s that a reduced maternal serum alpha fetoprotein along with a thick nuchal fold was actually going to be an excellent method for us to actually detect Down syndrome. And then we evolved the triple test and the quadruple test and then first trimester screening. And finally, the new game. I call it game because some of us don't know how to handle it appropriately, and we hope to sort that out so that it becomes a clinical tool and not just a game. And therefore, we will today discuss all that we can about NIPT. because things change. I mean, like day before yesterday, I was looking at Springer Nature and they said, look, we missed out in the year 2000 when we announced the whole genome project, that 8% of the genome was actually missed out on that. And now they've discovered it. It increases the number of DNA bases by about 4.5%, and the count of genes increased by just 0.4%, but it's going to tell us about how genes are regulated. So that's how rapidly things change. In 20 years, we actually have discovered that we still don't know enough. And the same thing is happening in NIPT, that every day there is something new and we realize we don't know enough and therefore we have to do it. And it's not that we have to look at a change ahead. This change is now here already. We have to decide we go with the change or we don't go with the change. And the first thing we must realize is that although we call it non-invasive prenatal testing, truly it's a screening technique, not a diagnostic technique. And therefore we should have been calling it NIPS, but the name NIPT has stuck on. That technologically it's the assessment of cell-free DNA in the maternal circulation. And we will hear more about it today. We will also take you through a relevant recap of conventional screening, the essentials of NIPT, the change scenario, because it is now being clearly recommended for certain clear areas of use by various medical societies all over the world. I have with me, as you've heard already, a most illustrious panel. And I also like to take this chance to acknowledge the help of Dr. Hasmukh Lal from Titlaghar. He's been a pioneer for putting together a lot of our SFM regional chapters in the East. And he has helped me a lot with what we should be talking about. He's in the US these days, but his inputs are greatly appreciated. And we will take you through the why, when, and what next of all of this. And we start off, before I ask my question, to remind you that we have screening tests and diagnostic tests for Down syndrome, just like we have for many other things. And diagnostic tests are the ones that give us a definitive diagnosis, while screening tests will just tell us which part of the population needs further testing. We know that diagnostic tests are fairly good and they show almost all the affected fetuses. However, because they are expensive or they have an inherent fetal loss rate, such as an amniocentesis or CVS, however small, and however becoming smaller and smaller as the years are going by, it's still not 100% safe, and therefore we do have to consider that we don't use it for everybody. Screening tests, on the other hand, are safe, relatively inexpensive. They do not identify all affected fetuses, which is a false negative, and sometimes they have a false positive, which we will discuss when we discuss the evolution of all these tests, because they do evolve, because we want to increase the detection rate. We want to reduce the false positive rate. We do appreciate the risk of invasive testing. We do understand that in parts of our great country, we have unreliable serum screening, and in some parts we have unreliable NT assessment. And therefore, we've been pretty much now realizing that although our sensitivity is going up, moving from about 65% of the second trimester triple test to about 75 to 80% of the second trimester quadruple, to a first trimester combined, which is 90% detection rate, to cell-free DNA, which is almost 99% plus. And this is what we will discuss today, and then let ourselves know that, yes, this is what we have to do. So starting with my first question, Dr. Ratnapuri, what is the scientific basis of NIPT, non-invasive prenatal testing, and how is it done?
So good evening, everybody, and welcome to this session. So traditionally, you know that the DNA is in the nucleus in a cell. That's what we've learned in biology all our life. But when we talk about NIPT, we are looking at something that is referred to as cell-free fetal DNA. That means this is DNA that is lying free in the blood. It is not in a nucleus, and it's very distinct from the DNA that's present in the nucleus. So these are small fragments of DNA that are present in the maternal blood. Now, when we take a sample of the mother, there is maternal DNA and there is fetal DNA. So where does this free maternal DNA come from? It predominantly comes from the hematopoietic tissue. So remember, in our body, cells naturally undergo what we call apoptosis or cell death. That's a normal process of regeneration and generation within our body. And so when these cells die, they release the DNA. And that's how the DNA comes into the blood. So this comes from the hematopoietic tissue in the mother. It comes from various organs in the mother. And it's important to remember that because this will have implications. And these are things that we would discuss subsequently in the panel. So what we really want is the fetal fraction of the DNA that is present in the blood. Now, where does this fetal fraction come from? It comes from the placenta. And all of you know that because that has been repeated many, many times. So it's the placental representation of the fetus. So, the basis of all NIPT is that we are taking a sample of the mother's blood. We are not able to separate the mother or the fetal DNA. It's not as if we are only sequencing the fetal DNA. We have already sequenced and we know what are the peaks of the maternal set of chromosomes because we are doing something called next generation sequencing or massive parallel sequencing, which is high throughput sequencing. So we are reading every bit of our chromosomes point by point. And we are reading it multiple times because when we are doing something very vast, we have to do it in depth to be able to capture everything. So that's trying to put it very simply. And this is the technology that is used. That's next generation sequencing or exome sequencing or NPS. So what they do is they cover all the 23 pairs of chromosomes. We know what we should get in a non-pregnant lady. Now, when we take a sample of a pregnant lady, which has maternal as well as fetal DNA, if there is any deviation from the normal, it comes as a change in a height peak. And when we see that change in a height peak from a background reference, we know that there is some abnormality. And because the mum's things very rarely change, we presume that that is of fetal origin. And this will also help you to understand why this technology will always remain a screening test and not a diagnostic test, because we are making many assumptions. Okay? So I think that is putting it very simply, how it's done and what is the scientific basis. And one more thing is, I saw a question up there, what's in the Streck tube? That's the secret as to what is in that Streck tube, because that's the special tube you collect the blood in. You cannot collect it in a normal EDT or a heparin packetainer. It's a specific anticoagulant. Nobody knows, only the companies know what is there in the Streck tube. And you have to mix it very gently, so you just don't tell anybody who's taking a blood sample that you go and give your sample. We do it, we've trained people, they go with the patient, they collect the sample and they mix it very carefully so that, you have to form something called a Buffy coat when the tubes stay, because that's how you're able to get the part of the blood in which the test has to be done. So I think I've mostly answered most of it.
Yes.
Well, yes, there are these other ways which are up there on the screen. So one is you sequence all 23 pairs of chromosomes, and that's massive parallel sequencing. And that's how most of the companies operate. You cannot differentiate by the method of sequencing what is fetal and what is maternal. The other is you only sequence targeted chromosomes, 13, 18, 21, and the sex chromosome, but you're sequencing them fully. The last technique is what we call SNP-based testing. That is a fascinating technique, actually. And there, because you are sequencing specific signatures on the chromosomes, and the signatures in the mom and the signatures in the baby are different, it's called SNP-based, called single nucleotide polymorphisms. We all are different because of changes in our DNA. So remember, every change is not equal to abnormality. Changes are equal to normal differences. So we utilize that in that SNP-based technique. And that is one technique by the method of sequencing where we can differentiate the mother from the baby. So these are the predominant technique, but I think all the companies now, so Natera is the only company which is doing the SNP-based testing. Most of that, what is available to us freely in our country, is the massive parallel sequencing, which is good. They've compared these various techniques and they've all found them to be okay.
Thank you for that. There's one more question I wanted to have here, and that is that the companies keep throwing new things at us. And they said, well, to make it cost effective, we don't do sequencing, we don't do a microarray on the cell-free DNA. You don't need a separate PCR room, and so so the job becomes easier and cheaper. Is this all hype from the companies, or is there something more to it in technology? And is that truly what makes it cheaper? Or they just acknowledge the fact that we can sell the technology cheaper?
So from what I really know, I think most of it is sequencing based. They do utilize other methods like differences in methylation between the mother. So you see, like I told you, the mother and the baby have different signatures. Now, what does this mean? There was a company which came in that we would utilize the methylation signature. Methylation is something that happens in our DNA to stop the DNA from making a messenger RNA and a protein. We know that there are methylation differences in the baby, which is really equivalent to the placenta here, and the mother. They had started using these methylation signatures and had said, yes, we can give it to you for 5,000 rupees. But it really never came into the market. It really never worked. I feel that the reason why things have become cheaper is because next generation sequencing per se has become cheaper. It has become more robust, and the algorithms. Now, what are these words that I'm using, like algorithm? So when you do an algebra sum, there is a methodology in coming to an answer. So that is the algorithm for solving that sum. Similarly, when we sequence so much, we get things like 30 GB of data when we sequence all our chromosomes. Out of that 30 GB of data, you have to make sense. Is a chromosome increased? Is chromosome 21 increased? So you put all that data into an algorithm. It's a bioinformatics pipeline, what we call. So we've all developed our own bioinformatic pipelines, which come better and better as we understand more, as more things come into literature, as we discuss more. And you put it into that. And because these things are becoming more freely available, there is more information and there is more competition. I think that's what brings the cost down more than anything else.
Thank you very much for that. And what about automation? Has that helped as well? Or is automation something?
Yes. So when it started in 2000, it was hardly automated. They used to take so much time to sequence one genome. And now with automation, it doesn't take time. They sequence many genomes together. It is not the sequencing which is the challenge. It is the analysis which is the challenge. And now we have what we call cluster machines, where you attach it. So you have special computers where they analyze the data. And we talk about cluster machines where you can analyze 30 genomes together. And there was a time when we used to do one genome over so many weeks. So automation has obviously brought in an ease of doing the analysis.
Thank you. Thank you very much. We will come back for more insights on this. My next question is back to basics, and that's for Dr. Bijoy Balakrishnan. Bijoy, can you let us know what is currently an ideal population screen for Down syndrome for patients who present in the first trimester? And what are the components of the first trimester combined screen? And what are the detection rates?
Actually, if you ask me, I agree that NIPT is a fantastic test. But for me, always the first line test is going to be the combined test. And the reasons are, I can explain it later on as we go through this webinar. And when you look at the combined test, the modalities that you look at are the NT, the age, the beta HCG, and the PAPA. And what we normally think is that it's only for Downs. And I agree that that's the most important thing that we look at. But whenever we look at serum screening, we're looking at a combination of of two things, basically the fetal function as well as the placental function. And so a combination of these things are abnormal in the combined test, and it tells you that there is a possibility of an aneuploidy there. And a combined test without any of the markers would give you a detection rate of around 90 to 95% with a fixed false positive rate of 5%. Now, I know all of us like to add in a lot of markers like ductus venosus, tricuspid flow, hepatic artery flow, and so many things. But it doesn't matter how many markers you add, your detection rate is only going to marginally increase, as you can see in the graph, from 95 to 96. What is significantly decreasing is the false positive rate, which drops from 5 to 2.5%. So if you're doing a good combined test with adding in all of your markers, you'll have a good detection rate of around 95 to 96% with a fixed false positive rate of around 2.5%. And as a corollary, you will also get detection for other aneuploidies if you get it in the high risk positive rate of greater than 1 in 100. Yeah.
Wonderful. And for those patients who come later on, how do you explain to them in the second trimester?
My go-to test in the second trimester would be the quadruple test. And if they miss that window also, then it would be just the genetic sonogram at around 20 weeks. If they miss everything and then finally land up very late in pregnancy. But it's important to understand that when you do your genetic sonogram, your detection rate is going to be less. Definitely your detection rate is not going to be that high. Your false positive rates are going to be high. And therefore you need a background test, like a combined test or a quadruple test. And it's always the last resort. But then as imaging specialists, when we get people coming in late, there is nothing else we can do but offer them a good genetic sonogram if they've not done anything else before. Yes.
Then there are some people who say, forget about biochemistry. Only a nuclear translucency. Is that really justified? After all, we fall quite low as 75% sometimes, which is just about the cutoff that the International Society for Pre-Diagnosis tells us a test should be worth. And of course, the reason why we dropped the second trimester triple.
Yes, the most important thing here is, first, when you use number of markers, your sensitivity increases, your detection rate increases. That's the first point. The second thing is that NT, although they say on paper that it's around 80%, I think it's around in reality, it would be around 70%. Because you're looking at just one finding, which is again confounded by a number of errors that people make while taking that measurement. Then the important point is serum biochemistry. When you're doing serum biochemistry, we're looking at two factors, beta-HCG and PAPA. They're actually looking at the ability of the placenta to produce hormones in a euploid or an aneuploid fetus. And in an aneuploid fetus, the production is going to be deranged. You're going to get high beta-HCG and low PAPA in downs. You're going to get low beta-HCG and low PAPA in trisomy 18, 13, and all the other kinds of triploides. So when you're doing your combined test, when the serum biochemistry is added onto it, and when it becomes abnormal, there is a chance that you will pick up not only downs, but you're also going to pick up a lot of other abnormalities that are going to be present in that 1 in 100 group. So if you're only going to do your NT and NIPT, yes, you might pick up downs and structural malformations. Am I audible? Yes.
Yes, yes.
Yeah, you're going to pick up structural malformations and downs, but you're going to miss out on all the other significant aneuploidies that are going to be present in those patients that are having a risk of between 1 in 100 and above.
And what if we threw away NT altogether, saying in my colony, my area, my city, the NT is useless?
It doesn't work that way.
Exactly.
You have to do the NT. You can't just do biochemistry. If you're doing proper screening, you have to do the NT and the biochemistry together. Yes.
Yeah. So as the best population test, then do we conclude that the first trimester?
Absolutely. That has to be your starting point.
Plus beta-HCG and PAPA should be our starting point for population screening.
Absolutely. No doubt on that. Yeah.
And then, thanks, we'll come back to this in a little while. But what I really wanted to come up with now is a very important question. And this is for Dr. K. Aparna Sharma. We know that India has two clear parallel streams of healthcare. There's government, where precious little is paid for, and private, where it's all out-of-pocket expenses or private health insurance or employee reimbursements and so on. So in these situations, when we know that an NIPT has greater than 99% detection rates, should we just do an NIPT and a 12 to 13 week scan, or NIPT plus a 12 to 13 week scan plus a combined first trimester screen as we just discussed? Or we do NIPT plus the scan plus the combined first screen and a PE screen, which would then include PLGF, of course? Or should I just get away with NIPT plus 12 to 13 weeks and a PLGF?
A very good evening to all of you. And sir, I think I feel like I'm doing MCQs here.
Yes.
So I would say that let us just see three things here. Number one, as Dr. Bijoy also said just now, that 12 to 13 week scan is something that has to be done. So that is point number one, and that is we keep it aside. Number 2 point here that we see, and that is something that we really need to adapt and understand and somehow internalize here, is that we need to start offering some kind of preeclampsia screening. So we need to start understanding it, and PLGF, we will come to it sooner or later, we'll start accepting it, but somewhere we need to adopt preeclampsia screening by doing a historical screening plus a biophysical screening, which should include a blood pressure and uterine artery Doppler. So at least that is something that we should accept and adopt for the time being. So the third point that you have written as preeclampsia screening is something that I would really accept immediately with PLGF or without PLGF. So that is my point number 2. Now we come to the contentious point here, and the point of debate here is NIPT or without. So that is the main point of contention. And now I would say, look at the patient. Just because the patient has money doesn't really mean that we offer NIPT or do NIPT in all. Again, as I said, look at the patient. Why look at the patient? What is the patient profile? Is the patient of advanced maternal age? What is the age of the patient? What is the patient profile again? Number one, as a healthcare provider, we need to inform the patient that there is a test like NIPT, which has a very good detection rate for chromosome 21, 18, 13, and X and Y. So this is something that we need to definitely offer. But at the same time, there is something called a pre-test counseling, where we tell that in a low risk population, you are a young patient, you are 23-year-old, it has a low positive predictive value. It might not add to your test value. And at the same time, if you do not do a combined test, you might miss out on something like Dr. Bijoy already mentioned, on being able to detect other chromosomal abnormalities, also other adverse pregnancy outcome predictions like preeclampsia and fetal growth restriction. So when we are trying to decide between NIPT and combined combined screening, dual marker, that is PAP-A and beta-HCG, please be very careful. Look at the patient. If the patient is of advanced maternal age, or she has a previous pregnancy which is complicated by trisomy, or you find some other indication where you are very tempted to do NIPT, you can definitely think about NIPT. But an absolutely low risk patient, no other indication to do NIPT, number one rule, offer NIPT, but at the same time with a good pre-test counseling, that if you are missing out on a dual marker, you are missing out on a very good chance to look at other chromosomal abnormality. You are missing out on looking at the prediction for adverse pregnancy outcome. So I would be very careful on routinely, universally offering NIPT. But yes, I mean, PE screening is a must in some form or the other, with or without PLGF, if possible. And 12 to 13 week scan is a must. NIPT population selection is a must. One last point that I would like to place here is that NIPT, on an average, if you offer for all and you look at the cost, even in an Indian scenario, that you look, even if everything is reimbursed, at any point in time is 3 times the cost. You look at your double marker, just double marker, or a contingent screening where the risk comes high, or an intermediate risk, and then you offer an NIPT. So this is my last point that I would like to put.
Excellent. And we will be discussing contingent screening in detail very shortly. So basically, you suggest that there has to be pre-test counseling, extremely important. There has to be a cafeteria approach, and then the patient can choose for themselves, but there must be appropriate emphasis on what is done for a whole population and how much is likely to be the benefit. Of course, a lot of us in our busy practice may not be doing that, but ideally speaking, we have to have all this put into a pre-test counseling. So moving on, my next question is for our friends from radiology. And Dr. Krishna Gopal, what are the possible components of a 12 to 14 week scan today? And what bearing does this have on the relevance of NIPT?
Thank you, sir. And good evening, all of you. So, as my earlier two panelists, Dr. Bijoy and Dr. Aparna has pointed out, that not only aneuploidy screening that is based upon the soft markers like the nasal bone, knuckle translucency, tricuspid regurgitation, and absence of A wave, the reversal of A wave. Our 12 to 14 weeks scan has also been evolved. So now we should include a screening of open the spina bifida by measuring intracranial translucency, that is the anteroposterior diameter of the fourth ventricle. We should not stop here. We should also do the screening of preterm birth by seeing the cervical length. And if we see that it is a short on the transverse abdominal scan, we should do the TVS also. We should extend our scan to include all the possible congenital anomalies at this time. Besides all those things that we do in our routine scan, like the dating, maternal environment, placenta, amniotic fluid, chronicity in cases of twins, and a detailed anomaly scan. So it has also evolved on the period of the time.
Thank you. And so essentially then the NIPT will need to know how pregnant the patient is. After all, we can't do it before 10 weeks.
And if we are seeing any soft marker and the ultrasound findings, most of the guideline suggest doing diagnostic testing than NIPT in this case.
Yes, and we move on straight to invasive testing. And of course, NIPT will require to know how many number of fetuses and make sure we exclude a vanishing twin and so on. Yeah. So moving on to our next question. Thank you so much for that. Our next question is again for Dr. Ratnapuri. Please tell us more about fetal fraction. Every time we keep hearing about this and we don't get to know too much, what does it mean? Are there reliable minimums? And how is a low fetal fraction overcome? Because invariably, you'll spot this somewhere in the report. What are the implications of this?
So fetal fraction is the amount of DNA of fetal origin in the total amount of DNA that is present in the mother. Okay, so that is important to know. And actually, the consensus on this is variable. However, most societies and most providers lean towards the fact that a fetal fraction must be noted. There are various methods of measuring fetal fraction. So it doesn't mean that a company which is giving a fetal fraction of 16% is better than a company that is giving a fetal fraction of 8%. So there are differences in the methodology and thereby the percentages we get. There is also no universal cutoff. There was a time we were using 4%. We also used to hear that if you have a fetal fraction of 8% and over, the confidence with which you can say, well, yes, there is no aneuploidy in that fetus was much higher, but things have changed over a period of time. So now they don't have any definite fetal fraction lower limits, but yes, every lab, based on how they are doing it, are they using the Y chromosome, are they using methylation? There are various methods of measuring fetal fraction. They are able to give their own lower limits below which they would not report. It would come back as a no call. So that is very important. And as far as we are concerned in India, I think we do have we are in a position where we need to have a fetal fraction in our report. So at least we know that the laboratory is measuring a fetal fraction and they know what they're doing, because we've got many, many labs which mushroom, which may not be accredited, which may not be so experienced, etc., etc. Okay. Now, the next question was, what do we do for a low fetal fraction? So how is a fetal fraction impacted? There are maternal reasons and there are fetal reasons. So if you have a mother who's overweight, everything gets diluted, so you get a low fetal fraction. If she has active autoimmune disease, the fetal fraction decreases. It was interesting now that there is data coming in. If she's on low molecular weight heparin, it may impact the fetal fraction, but we are not so sure as we are in other situations. And the other things related to the pregnancy are, if it's before 10 weeks, the fetal fraction is very low. If the gestation of the baby, so it correlates with the CRL of the baby, it increases as the pregnancy increases. This about the PAPA and the HCG is also variable. How do they impact the fetal fraction? Initially, we used to believe that when there is a no-call rate, there is a very, very high probability that the baby could have Down syndrome or trisomy 13 and 18. But there is new data now which is refuting this. It's not necessary. The one thing that we know is that triploidy does decrease the fetal fraction. So you could get a no-call rate. So it's very important that a lab recognizes that below a certain fetal fraction, they would not report off an NIPT. Yes, even artificial ARTs, artificial reproductive technology, IVF decreases the fetal fraction. And in twins, what happens in twins is the total fetal fraction increases. But when we take an individual twin, that representative fetal fraction is low. So these are the various things.
Thank you.
I missed anything here?
Yes, you see, what I wanted to really bring out is what you've already told us, that the concept of fetal fraction has changed. The value is the same, but we no longer go by the cutoffs of 4 and 8%, that different companies handle this differently, that what was traditionally thought as being not so nice for us, such as the levels of the placental hormones and the so-called presence of trisomies, etc., does not hold good. And we know that NIPT came up in 2011. This chart is from 2015 from no less than Peter Ben himself. And that now this chart doesn't hold good today, which is why we're specifically holding webinars like this, to let you know that knowledge is evolving constantly and you just have to attend all our webinars. But we will bring this information to you from time to time. And we do hope that at Society of Fetal Medicine, we will now start a newsletter, which will not be just about events, but also giving you fresh insights every few months on how the world of genetics and ultrasound and fetal medicine changes so rapidly. Moving to our next question, and this is for Dr. TL and Praveen. What are the NT measurements at which we move directly from not sending the patient for screening? Okay, so sorry for that interruption. The question is, what are the NT measurements at which we move from screening to invasive testing? Do we use just centiles? Do we use standard deviations? Do we use multiples of median for gestational age? Or a straightforward cutoff of 3 or 3.5 millimeters? And what do we do with obvious nucleedema or thick nuchals before 11 weeks, in the time of 9 to 11 weeks? So could you give us an insight on all of this?
Yeah, good evening, everybody. And thanks, Ashok, for this question. And thanks, Raipur team, for involving me in this. And this is one of the most important questions that we will be coming across in our day-to-day practice. We all know that NT is a well-studied ultrasound marker for common and uncommon aneuploidies, as well as wide variety of genetic syndromes and structural abnormalities. Now, the present thinking is that the fetal nuchal translucency of equal or more than 3.5, which corresponds to 99th centile, is a definite indication for an invasive testing. This is one thing which we have to be very, very clear. Now, there are certain cohort studies as well as the literature reviews which have suggested, particularly by the AOGS, that is the Scandinavian Journal, in April 2020, where they have suggested that even a nuchal translucency of 3 millimeters also has to be considered, because there are certain anomalies, or there are certain chromosomal aberrations to the tune of 1 in 7.4 or 1 in 14 pregnancies, where the NT is 3 or 3.4. And actually, when you take the 3.4 as the cutoff, it corresponds to 95th centile. So these are the things that we have to keep in mind. And now, whenever we have this sort of a situation where we have an NT and do a combined screening and then try to sort out or categorize them, and we get into an intermediate risk where we would like to do an invasive procedure or an NIPT. Now the contention is between the NIPT as well as the invasive testing. So that is one thing which we have to also keep in mind. Now, coming to the third question, I think the first two questions, I think I have answered enough, right? And the third and the most important question that we need to keep in mind is the obvious nuchal edema, that is between 9 to 11 weeks. First and foremost thing, nuchal edema is most likely a multifactorial thing. It's a combination of delayed or disturbed lymphangiogenesis, cardiac as well as the vascular malformations, and abnormal extracellular matrix components. Now, whenever we have a nuchal edema at 9 to 11 weeks, that is quite often what we do, what is known as the pre-NIPT scan, in which if you find a nuchal edema, there is it's a very potential early marker for both structural as well as the chromosomal abnormality. And the incidence of chromosomal abnormalities increases with the severity of the nuchal edema. And not only that, a most important thing which we also have to keep in mind whenever we find this nuchal edema in 9 to 11 weeks or before 9 to 11 week scan is that it could be because of fetal infections, it could be because of fetal anemia, or it could be because of thalassemia or TTTS. So these are the things that we have to also keep in mind. And whenever we have this sort of a situation, all these features should be followed by a detailed anomaly scan or the structural scan at 11 to 14 weeks of gestation.
Thank you. That makes it nice and clear, and very clear steps forward. We move on to our next question, and this is for Dr. Aparna Sharma. Apart from the greater accuracy of first trimester screening, what are the advantages of a first trimester 11 to 14 weeks evaluation, and what is the hurry?
So, sir, as we have been talking about, the prediction of, the outcome of pregnancy. So till now we've been talking about aneuploidy, and there was this recent comparison that I came about that we are so fixated on screening for aneuploidy that the occurrence of actually the preeclampsia and growth restriction is much more than Down syndrome. So if we try and utilize these markers for prediction of preeclampsia and growth restriction, maybe we'll be more benefited also. So we should also try and use these markers. And I am also an obstetrician, so I know that we don't actually look into these markers. When we know, so we just look at that graph which says and tells me the final figure, okay, the risk cutoff, and we say, okay, low risk. We never even look at those MOMs which tell me that what is the final MOM. And I have to know, I know that if I say that if the PAPA tells me that it is less than 0.5 or 0.4 MOM, I have to be really careful that, okay, maybe this pregnancy might be at risk for adverse pregnancy outcome in terms of, preeclampsia, FGR, or, all of those things. So what we really need to understand is that there is evidence to say that if there is low PAPA, if there is a PLGF, we are able to do, there is association to prediction of development of preeclampsia. FGR, there is still time to develop, but there is actually, we need to look into it. So these are some of the things that we need to actually think about when we are doing a 11 to 14 week evaluation. Also, this is the best time, as we have seen the 11 to 14 week scan, and as radiologists, so most of you are, some of you must be radiologists also. So the dating scan, twin pregnancy surveillance, as has already been mentioned. So all of these, the basic components of 11 to 14 week scan, we should not forget. And most importantly, what I also feel is that this is a huge window, that if you have detected that this is a high risk pregnancy for development of preeclampsia, we have to start aspirin before 16 weeks of pregnancy. Because if we start aspirin after 16 weeks, it has been found that it is not useful. So we should start aspirin before 16 weeks in a dose of 150 milligram. So this is the time of doing a lot of things. So we should be really be looking into it. And of course, this is also the time for a complete structural evaluation, because now we have really moved from a second trimester anomaly scan to a, thanks to the radiologist, excellent radiology skills and the machines, that it's a complete structural evaluation. So we can also look at what are the anomalies that are found. So complete evaluation and what is happening. So these are the things that we can, extra things that we can look at a 11 to 14 week scan.
Thank you. And most of these results are available by about 13 or 14 weeks when we talk about them. How much easier is a termination of pregnancy for something that a patient opts for at 14 weeks, say, compared to 19 and a half weeks?
Right. So I think, sir, it is pretty, I would say, simpler at 14 weeks as compared to 19 weeks, where we are really pressed for time and we are really hurrying with the MTP law and, standing on our heads. So at 14 weeks, you get an 11 to 14 week scan and you have some serious doubts and what has turned up. So I think you can easily go for a termination of pregnancy rather than, wait for an 18 weeks, detect something at 18 weeks, then you're in a doubt and you go for a second opinion. And then, you want to get something tested. You want to have some genetic diagnosis that will take another week's time. So, and then you have that 20 weeks timeline. So all of these things. So it is always good to have 11 to 14 weeks evaluation now, because the major things can be detected at this time. You have time for a genetic evaluation, good counseling, termination, and then you get the baby also evaluated if it is required.
Thank you. We move on to our next question. And this is for Bijoy. How do you incorporate NIPT as a secondary screen or a contingent screen after a first trimester combined screen? And if you could tell us the recommendations of the Fetal Medicine Foundation, as well as your personal experience.
Thank you. So this is a kind of a long answer.
Yes.
Yeah. So I think I don't agree with the concept of giving NIPT to all. Basically, the reason is the negative predictive value of both the combined test and the NIPT is the same, which means if you get low risk on your combined test and low risk on the NIPT, both mean the same thing. You don't have downs. They have the most equal significance. And that's why you should not, stratify women into high risk and low risk and then offer NIPT to high risk thinking that there is an advantage for that. I would suggest combined test for all and use a contingent model. Now, what was the purpose of NIPT? The purpose of NIPT was not only to increase the detection rate of Down syndrome, but also to decrease the invasive test. Now, what I see most commonly being done with the NIPT is that they stratify women into risk groups like 1 in 200, 1 in 250, 1 in 250, and 1 in 1000, and 1 in 1000 and above. And you offer NIPT to all those women between 1 in 250 and 1 in 1000. When you do that, you're not decreasing your invasive test rate because you're already going for invasive to all those women who are above 1 in 250. So if you want to decrease your invasive test rate and increase your detection rate, you should do a baseline combined test and divide them into 3 groups. The first group would be the high risk group. The second group would be the intermediate risk group. And the third group would be the low risk group. Now, where do you place these cutoffs? What is the cutoff that will decide which is high risk? What is the cutoff that will decide which is intermediate risk? And what is the cutoff that will decide that is low risk? Now, the Fetal Medicine Foundation thought of a number of ways, and they decided to use, in some places, is 1 in 10 and 1 in 50. But I think from my experience, what I have been doing is that we have divided and segregated them into 3 groups based on the combined test report using 1 in 100 as the first cutoff. So anybody who's got a risk of above 1 in 100 gets an amniocentesis. Between 1 in 100 and 1 in 1,000 gets an NIPT. And those who are above 1 in 1,000 go home scot-free. Now, the ideology or thinking behind that is, when you have a woman who is in the range of above 1 in 100, there is a good chance that there will be downs in that group. There is a good chance there will be other chromosomal abnormalities in that group. In fact, 75% of your other chromosomal aberrations are going to be in that group. And so it's better to do an invasive test in that group. The ideology behind FMF is that 50% of the other chromosomal abnormalities are present in the 1 in 10 and higher group. But when it comes to, I think we need more clarity on that, and that's why above 1 in 100 would be a better cutoff for us to use. And by decreasing the cutoff from 1 in 250 to 1 in 100, that group between 1 in 100 and 1 in 250 does not get an invasive test. They get an NIPT. So what happens? Are you bringing the invasive test rate down? You are. So you're bringing your invasive test rate down, and in that group, you're giving NIPT, that is 1 in 100 to 1 in 1,000. And therefore, by this scheme or by this method, you have a detection rate close to around 98 to 99%, much higher than doing just a combined test, and much more cost effective than doing NIPT for all. And you pick up all the other significant chromosomal abnormalities. It can't get better than that. That's what I think.
Wonderful. And how much evidence do we have for these cutoffs, say of 1 in 100?
Yeah. This 1 in 100 cutoff is from the same paper from which they derived the 1 in 10 cutoff. So the 1 in 100 cutoff, when they said that if you use a 1 in 100, 75% of your other chromosomal abnormalities are going to be present, but 50% would be present in the cutoff that is less than 1 in 10. So why miss out on that 25%? You might as well increase your cutoff to 1 in 100 and offer invasive testing to that group. This is the same paper done by Edward Gretakos and Kypros Nikolaides, and they came to that 1 in 10 mark because they felt that 50% of their other chromosomal abnormalities is present in the 1 in 10 group.
Wonderful. So it's now very clear that instead of fiddling around with anything that was 10 or 50, 100 should be a great way to sort of guide our counseling.
Yes, and I would like to make another point here. I have seen the reports, the combined test reports. Some of them come with an advice underneath it, which tells you that you are in the intermediate risk group. So for example, if you have a woman who is, say, 1 in 300, it comes with an advice underneath, you are in the intermediate risk group, suggested NIPT and so on. I think it's totally wrong, because the cutoffs that they use, most of the companies use, is 1 in 250. And when you use a 1 in 250 cutoff, the only thing you're doing is, maybe you might be increasing your detection rate for downs, but actually you're not bringing down your invasive test rates. Your invasive test rates are still going to be the same as what it was before the pre-NIPT era. Because in the pre-NIPT era, you were still using 1 in 250 cutoff. So it does not change your invasive test rate. So that's why I feel you should bring down the screen positive rate from 1 in 250 to 1 in 100.
So we should now follow that. After all, it has evidence, and it has evidence on a very large scale. And we don't go by what the companies dictate to us. Dr. Aparna Sharma, would you agree with that?
I completely agree with Dr. Bijoy. Actually, there is another study on his, which is not from the Nikolaides group, which also says that they also found, and they were really concerned that because there is another basis to do that, because they say that they also said that suppose you offer NIPT to all of the patients who turned positive on combined first trimester screen, then are you actually missing out on major chromosomal abnormalities? So it is actually other way of looking at things. And they said that if you decide a cutoff of 1 in 100, then you actually miss out on very less chromosomal abnormalities. So it's actually a different way of putting the same thing, that 1 in 100 is a safe cutoff, right? So you are actually arriving at the same thing. But I actually have a very different concern that the standards of labs are not the same everywhere. Right. So that is a very major concern. And that is another reason why the cutoff in a number of places is 1 in 250. And so that is maybe, one of the reasons. And with the more safety of the invasive procedure. So the universality of 1 in 100 is something that really needs to be seen. So my concern is just that. So I have serious issues with that.
So we have now to wait for how knowledge and experience evolves. but for now it would be wise to use 100 as a cutoff. Look at the labs carefully, make sure the lab has your reputation or that you've been following with the same lab and you've had
Yes,
a good.
the lab has to be good. Yeah.
Yes, and otherwise, after all, labs have been reduced to collection centers now, where even the patient demographics is not filled in properly, and people easily don't mention diabetes, they don't mention IVF and things like that. So that's a complete disaster. So we really have to make sure that every line is to be read. Dr. Ratnapuri, is there any suggestion that you say of how we should be looking at these reports that come in from the various labs when we look at a combined screen?
I think the first thing we have to do, like you said, look at the demographics. And something that I find very frequently is the date of birth, which is incorrect. A large percentage of our population has an official date of birth, which is, which is what they give, because the patient doesn't know. So it's, I think, the doctor who is ordering the test. I do not expect the person at the collection center to fill in these details. And I think that is all wrong. And it is the doctor who has to write very clearly. Unfortunately, the screening test is written as a part of a gambit of tests from CBC to HIV to HBsAg, and at the bottom you have dual marker written. I think that's the wrong way to do it, because you haven't counseled the patient anything. All these tests have to come with pre-test counseling. You have to tell them what it's about. You have to tell them what a screen positive is. And on a paper where you order the test, you have to write name of the patient, date of birth, what is the LMP, what is the date of the ultrasound, the CRL, the NT, the NB, whatever you want to put into that report. And I think that's the primary responsibility of the doctor who's getting the test done.
Thank you.
And for people who are evaluating the reports and have not done them themselves, not ordered it themselves, have to look into this. So you actually have to start from the top of the report and not just look at, the red where they say high risk or low risk, or as Bijoy said, the new thing which they've started writing is an intermediate risk.
And of course, the name of the patient. Because very often you find they're just one half name and you're never absolutely sure. Moving on, Dr. Ratnapuri, what else can NIPT do apart from a high efficiency screen for trisomy 21? How does it perform for the two other common autosomal trisomies, or CATs as we've started calling them, trisomy 13 and 18? How is it for our sex chromosomal abnormalities, for the rats, the rare autosomal trisomies, and for microdeletions? And what do the professional societies recommend for rats and microdeletions? And at the end, I would again like to ask you, what is the status and availability of NIPT for RHD status?
Okay. So I think it's very important to give a message that NIPT is primarily for trisomy 21, as the combined first trimester screen started for trisomy 21, and the other two, 13 and 18, piggybacked upon it. The reason for that is that they are fairly rare. Okay, they are not common, and but the NIPT does fare well for them also. So the 2017 paper by Gills and the Nicoloides group, and nothing has come after that, say it's 99.5 to 7% for trisomy 21. It's about 99%, I think, for trisomy 13, 98% for trisomy 18. And it's the lowest for Turner syndrome, which is 95%. And there are various reasons for that. But still, I think for these disorders, it is all right. And we don't worry so much about 18 and 13, at least for 18, because if you've done good scans, you do find abnormalities in the scan, whether at 12 or at 16 or 18 weeks. Now, coming to the rarer trisomies, I don't think we should be blowing our brains on them. Most of them are not compatible with life. They would be in a mosaic state, some of them. But I think as far as everybody is concerned, we are not ordering NIPT for the rare autosomal trisomies. And in fact, that is the reason why we don't do, NIPT very early in pregnancy, because a large number of these pregnancies end up in a spontaneous miscarriage, as would a 30% of trisomy 21s also end up in a miscarriage by about 16 weeks. So we have to keep that in mind about when we are, what time in a pregnancy are we doing an NIPT. And then we also talk about the microdeletions. So let me tell you that no society recommends either the microdeletions or the rare autosomal trisomies, which is why I started off by saying it's for, just the common disorders we've discussed. The reason for the microdeletions is that most of the microdeletions are very rare, so we don't worry about them. There is trisomy, there is 22q11.2 microdeletion, which is not so rare. It may be 1 in 1,000, 1 in 2,000 now that we are identifying more with NIPT on a research basis. But the positive predictive value is very low. And thereby, it is not still recommended until we have more data related to that to order NIPT for the chromosomal abnormalities. Other than 13, 18, 21, the sex chromosomes piggyback along and that's okay.
So essentially then something like this chart, which says that the best clinical relevance and prevalence and evidence and performance would be for the common autosomal trisomies. And with everything, then it just goes down, 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 and down. And none of these is truly recommended as part of a routine workup. We must wait for more evidence before we offer these. Moving on to one more scenario, we hear increasingly about the FGFR3 related skeletal dysplasia and the fact that NIPT might actually detect thanatophorics, achondroplasia, and hypochondroplasia at 13 weeks. Is there any experience in India with this? Do we go by this?
Nobody would worry about thanatophoric because you would pick it up on a scan. Okay, it's a lethal skeletal dysplasia. Achondroplasia, hypochondroplasia, there are reports, and there is report from the UK group. I forget her name. But there is a Lynn Chitty. Yeah. There is data from the Lynn Chitty group that they have worked on the FGFR. They are not so difficult to pick up because it's not there in the mother's blood and it's a heterozygous mutation. But it somehow has not been reproduced. So obviously it's not very robust. And I think over a period of time, we now have definitive treatment for achondroplasia. So it would really go out of the window as something that we test in pregnancy and terminate a pregnancy for.
We can make a post-delivery diagnosis and then...
and treat the patients.
And what about the
state? These patients are intellectually fine.
Perfectly.
And my mind at times does not agree to discontinue pregnancies where there is not so much. And I consider morbidity really intellectual disability.
Yes. And what's the news on the RH group? That's where we started with NIPT, really.
On the what group, sorry?
On rhesus, on RH.
Oh, rhesus. Okay. So for rhesus, yes, it really started with rhesus. And it is a useful test for rhesus. And I think it's really relevant if we have genotyped the father. And the father is, if the father is ++, you don't need to worry about all this because the baby is going to be RH positive. If the father is plus and minus in his RH genotype, then it is relevant because you would monitor pregnancies accordingly. But remember, like NIPT, it is a screening test.
Yes. Thank you for that input. We move on to the fact that we really don't have any recommendations for anything except trisomy 21, 18, and 13, really, when it comes to NIPT. Would I be right in saying so at the moment, that this is the way that we must believe it until more recommendations come along?
Absolutely.
And we move on to some very quick answer questions. And the first of these is for Dr. Bijoy. A failed NIPT is very fashionably labeled as a no call. What are the possibilities in this situation, apart from a low fetal fraction, and how do we handle these?
Apart from a low fetal fraction, mostly it should be transport error or sampling error or something like that. So if that is the cause, then usually when you do a repeat sampling, usually you will get your result. But if it is due to low fetal fraction, then if you don't have a background test, like a combined test, then you don't know what to do with it. A mother comes in at 10 weeks or 12 weeks with a no-call result, and the best option would be to do a combined test. But if she comes in late, let's say 18 weeks or 19 weeks with a no-call result, then it's too late for us to do anything except then do a proper scan or go in for a quadruple test or something like that. Now, even though we used to believe that there used to be a high risk of aneuploidy with the no-call result, and I still believe that triploides, as Dr. Ratnapuri ma'am has said, is still a valid reason to be afraid of aneuploidies in the no-call group. But if you find a scan that's perfectly normal and everything is fine, then if you get a no-call result, then you can go back to your background combined test if you have done it, or offer them a quadruple test if they come in that window, or go in for a genetic sonogram if nothing else is available and they come in very late. It depends on what their background test is, basically.
Yes. So, of course, if they had a prior risk on that background test, we'd be quite happy. Otherwise, a detailed ultrasound scan would really be the starting point to decide whether we do invasive testing or we don't do invasive testing.
Yes.
Wonderful. We move on to our next question, and this is for Dr. Aparna Sharma. Is a no-call on NIPT a sufficient risk marker for starting low-dose aspirin and increased surveillance for poor obstetric outcomes such as preeclampsia and fetal growth restriction?
I think this is something which is an evolving evidence. The most recent study, they looked at almost 2,000 pregnancies with low fetal fraction, and they said that there's almost 2 times increased risk of preeclampsia and 3 times increased risk of preterm birth. But there is another similar paper which was almost 3 years back, and it said that there's actually no increased risk. So I think there's still some conflicting evidence, and maybe we'll have more evidence in the recent future. But right now, I don't think we'll be doing that.
Excellent. So we put that on hold until we have more evidence. And we move on to our next question, and this is for Dr. Ratnapuri. What are the limitations of NIPT in patients with organ transplants, with maternal malignancies, maternal chromosomal disorders, and the mosaicisms, and how should we handle these?
Okay. So now I really want to bring you back to what I initially told you. Where does the maternal cell-free fetal DNA come from? It comes from the hematopoietic system, and it also comes from cell death that is happening in the various organs. So if you have an organ transplant, remember that transplanted organ is also going to have apoptotic cells. And especially if it is from a Y chromosome, it will flag off abnormal because that's not the normal maternal complement. So you would have a false positive. Malignancy also, your malignant cells have various chromosomal aberrations. We normally do karyotype in patients who have malignancies because of, to identify the chromosomal aberrations. So these also would be picked up by NIPT. So you have a very sort of a bizarre pattern, again, giving you a false positive. Maternal chromosomal disorders, and this is an interesting concept. I mean, how would a lady with a, remember I said a chromosomal disorder is associated with intellectual disability. So how would a lady with a chromosomal disorder, be pregnant? So one are the sex chromosomal abnormalities. And amongst them, we have XXX. So that's 47XXX. Majority of them are asymptomatic and are picked up incidentally. So here, if the mother by chance is XXX, that would also be flagged off as abnormal on an NIPT. The other thing that we know now is as women age, they lose some of their X chromosomes, and they can be akin to something that is called mosaic Turner syndrome. And that is a situation, again, that would be picked up as abnormal in an NIPT. So how should they be handled? So you have to see, you will not do an NIPT in a lady with an organ transplant or a lady who's not in remission for a pregnancy. I remember many, many years ago at the start of NIPT, I had a doctor couple and she had breast cancer and she had been in remission for 2 years. And we got a abnormal NIPT, We did an invasive, the invasive was okay. And unfortunately, by the time she was about 7-8 months pregnant, they identified metastasis in the spine. So that was what was flagging off that abnormal NIPT, you know. So, so these are situations where you would not order an NIPT. And of course, for maternal chromosomal disorders, etc., there's nothing you would do. They do say that if you have a sex chromosomal abnormality that is flagged off in your NIPT and your amniocentesis is normal, you would do the karyotype of the woman. In India, I would not do that karyotype of the women. Poor things are maligned enough. And if, you know, the family finds out that she is 47XXX, they'll give her hell. So I don't think we do those things in our country, the kind of society we live in. But we just need to understand these.
Thank you. We move on to our next question, and this is for Dr. Bijoy. How does NIPT perform in ovum donation pregnancies?
If you're talking about NIPT that is using the SNP-based techniques, then maybe ovum donation pregnancies might be a problem, because in SNP, what we do is basically we try to differentiate the fetal fraction from the maternal fragments using the signature polymorphisms that are present on the fetal fragments. But as far as the sequencing methods are concerned, ovum donation should not create a problem, because we're just looking at the overrepresentation of a particular chromosome or an underrepresentation, which should be fine in the ovum donation pregnancies. I guess that's what you're trying to say, sir.
Absolutely, yes. And our next question, Dr. Parna Sharma, please put into perspective the role of NIPT in vanishing twins and in multifetal pregnancies in general.
So first of all, in multifetal pregnancies, I think it is now well validated and standardized that we can offer NIPT. So that is a blanket statement, and I would just leave it at that. So we are routinely offering NIPT in twin pregnancies now. For the vanishing twins, it's a bit tricky. So I would say that, you know, it has been a bit of a confusion. Even for biochemistry, we have not really offered, we should not really offer first trimester biochemistry for vanishing twin. Now for NIPT, like ma'am said, the fetal DNA from the vanishing twin, the twin which has actually had a demise, will persist, and it has been seen in the literature that it will persist from somewhere to on an average for 7 to 8 weeks. So if we have a documentation that, okay, you saw a twin and now there is no twin, so we know that it is going to persist for 7 to 8 weeks. So it was seen in a series of patients, around 600 patients, and they documented vanishing twin in those series of patients, and they actually did NIPT in those patients, and they found a sampling, a failure rate of around 7% at the first and 1.4 on a repeat sampling, which is almost equal to the general population. So they said that if you do NIPT in a vanishing twin after 15 weeks of gestation, you can possibly do NIPT after 15 weeks in a vanishing twin also. So number one, please be careful. If you are offering NIPT, please decide that you do need to offer NIPT. It is required, it is indicated. And if it is indicated, how much time has elapsed from the diagnosis of a vanishing twin? And it is reasonable to expect that it will take at least 7 to 8 weeks, and it has been reported even up to say 12 weeks. But if you can wait even after 15 weeks is a logical time period to do NIPT, and this has been reported in the literature also. So unless required, do not do NIPT. If it is required, please do in the later half, maybe around 18 weeks of gestation, where it is safe and you will not have sampling errors or you will not have a false positive NIPT.
Thank you. And our next question is for Dr. Bijoy. How reliable are NIPT results for trisomy 21? Does the positive NIPT for trisomy 21 always need a confirmation with invasive testing? And how do we decide between chorion villus sampling or amniocentesis in these situations?
The first question is how reliable NIPT results are. So there is a common confusion between detection rate and positive predictive value. Now, NIPT has a detection rate of 99, greater than 99%. That does not mean that whenever an NIPT is positive, the mother has a baby that has Down syndrome. For that, you need to know the positive predictive value. And the positive predictive value of NIPT is not 99, it's around 85% for the low risk woman and 95% for the high risk woman, which means that it's not 100%. So when you find that the NIPT is positive, it means that there is an overrepresentation of the chromosome 21. Now that could come from the placenta itself in conditions like confined placental mosaicism, where the placenta is abnormal and the fetus is fine. So it is possible that the placenta is generating that overrepresentation of trisomy 21. So whenever you have a positive result on NIPT, you will not go in for direct termination. You need to confirm whether the fetus is affected or not. For that, CVS might not be the best option, because CVS is again sampling the placenta, and the placental tissue is what is coming into the maternal blood. So it would be better to go in for an amniocentesis at 16 weeks. Now, this is kind of controversial, because there are groups that say it would be better to go in for a CVS if you do not have any markers present, and you can very well go in for CVS. But if markers are present and if you feel that there is a chance that it could be, you can wait till 16 weeks. It's like kind of a controversial thing, but I would prefer to go in for an amniocentesis personally, because that way the confined placental mosaicism is taken out of the question. That's what I think.
In the last 8-9 years that we've been working with NIPT, we've all sort of burnt our fingers once or twice, realizing that yes, the placenta was also as much of a mosaic, and the patient didn't really then terminate a pregnancy. She just decided to carry on irrespective, especially with her IVFs. And maybe it was to do with IVF, but we've had results like that. So we really must confirm everything with an invasive testing.
Yes.
We move on to our next question. And this is finding an opportunity for our imaging folks. Sorry for neglecting you so far, but the point is that there's so much in the chat box and in the question and answer section for you. We promise to do justice to your presence here. Now, Dr. Krishna Gopal, patients almost always come uncounseled for the 11 to 14 week scan. We know as radiologists, we face that day in and day out. Technically, you become the first point of contact if ultrasound does or does not throw up an issue. And how do you counsel them about screening options for trisomy 21 before, during, and after the scan? And how do you communicate with the referring clinician? Do obstetricians still get offended if you talk too much like they used to when I was growing up? And most patients and their attendants and families would expect inputs. They feel very shortchanged, dissatisfied if you didn't have a discussion with them. How do you handle all this on a daily basis?
Sir, basically, this is a very, very relevant question with several components, and it requires a detailed answer also. So, so basically, we are living in the second most populated country of the world with a poor doctor-patient ratio. So most of the gynec who are seeing 50 or 60 patients, they don't have really time to counsel them in detail. And with the faster attrition rate, high attrition rate, it is very difficult to train the staff also. So most of the cases when the patient come to us, they are not counseled. So the trick is to take a short detailed history, see on the prescription whether the dual marker has been written or not. If the dual marker has not been written, make them aware that there will be a blood test after this scan, and the purpose of this is to see the aneuploidy. At the same time, you should talk about your test also, because this has these components in your scan. As far as counseling to the attendants and patient, and counseling and discussion with the clinician is concerned, it is a very, very thin line. So it is very important to tell the patient honestly what you feel like, but at the same time, it is also important to communicate to your clinician what you have communicated to the patient, because then you both will be on the same page. Your doctor will be totally aware that what you have communicated to the patient. Plus, when you are seeing the patient, before doing that, you will make them aware about the test. When the test is going on, and if you see that suppose nasal bone is missing, or there is increased translucency, you should make aware the patient about these findings also. And after the test, it is better that you should call the attendants and make them aware about the finding in a shortest possible form, and then you communicate to the doctor. And sir, it is very important to build a trust with your referral doctor also, so that they should not get angry. They should trust you, that though you two have a different turfs, but you are not going to their turf. So I also felt the same kind of anger in my early days, but it takes time to build that bond of trust.
Thank you. That was really, really very, very practical inputs. Thanks so much for that. And it's a very, very wonderful, wise answer. We have just a couple of questions left. Dr. Ratnapuri, is this question about, is there an outer age limit for NIPT? I think I skipped that out somewhere, but we will have that. No, before that, this is for Dr. TL and Praveen. Beyond NT and additional aneuploidy markers, when you do have an anomalous fetus, how do you counsel for screening versus invasive testing? All patients now expect an opinion on the ultrasound when your examination is over. And does your referring clinician base still expect you to shut up, or you expected to counsel?
Yeah, I think it's very obvious that whenever we do an NT or find an abnormal structural abnormality in the fetus, invasive testing is a must, and in the sense it's definitely indicated and it has to be done. That is one. Now, why do we do this? This is basically to gather certain genetic information. Particularly, we need to have a comprehensive genetic information in order to categorize them as lethal and non-lethal, or correctable or non-correctable. At the same time, there are certain specific indications where you need to do specific tests. And at the same time, there are alert your pediatric colleagues to be prepared for eventuality. And at the same time, mode of delivery as well as the place of delivery has to be decided. Now, regarding the counseling of it, I think there is a sea change in the approach. Now, once we have diagnosed an abnormality in 11 to 14 weeks of scan, positively, I would like to reevaluate them at about 16 to 18 weeks before I talk to them about anything abnormal. But once it has been confirmed at 16 weeks, I would definitely sit with them, tell them about tell them everything about the abnormality, its progress, its prognostication, and at the same time, give this information to the clinician who has referred the patient to you, because there are certain situations where they may not be aware because of their busy schedule as far as managing these patients. So it is essential that we need to pitch in and then try to help them out, almost giving the same information as which we give to the patient and the attendant, so that they can also talk in the same lines. And that has been now accepted. Initially, it was not, but now it has been accepted. I remember very well, once I was told not to get into their shoes. But then now the things have changed a lot, and now they expect us to counsel the patient. And initially, the radiologist had a problem about counseling the patients because we were not trained in counseling the patients. But then over a period of time, we learned how to talk to them and how to convey the proper essence of what we have done as an ultrasound examination, and also convey the progress of the pregnancy and talk to the clinician. So I think this is what is very essential, and it is important that the present day practice of fetal medicine definitely has to include the counseling of the patients regarding their abnormalities.
The point I also wanted to ask you is that if you have a thick nuchal translucency or a megacystis, an omphalocele, a tetralogy of Fallow, for instance, And then you have a choice. Should I complete my biochemical screen? Should I cancel my NIPT and move on to a CVS?
Yeah.
Would that be completely justified at this stage? And you just cancel?
Yes, I think it is justified, particularly when you have a abnormality like a phylocytology or a omphalocele, which is definitely pathological. In that situation, definitely we would like to do an invasive procedure rather than do an NIPT.
Yeah, thanks for that. And next question is for Dr. Ratnapuri. Is there an outer gestational age limit on NIPT? And what will be the impact of the new MTP Act on this once the rules are framed?
So there is no gestational limit. You can do it till delivery. Okay, once the baby is out, then you can't do it, but you can do it till delivery, technically. And well, yes, if say you identify some soft marker, actually, if you identify something very late and it increases your risk, I'm not too sure it's a good idea to do an NIPT then. Because I think we still go by what we say, that if there is a malformation, you would do an invasive test, even if you strongly think that it's Down syndrome. Because if there is a major malformation and you first do an NIPT and the NIPT comes low risk, you're not excluding all the other chromosomal disorders that can be associated. So I'm really not too sure that it's going to impact it a lot at all, because there is no indication of doing an NIPT late unless really the woman has been sleeping and they just identify very late in life that she's pregnant.
Yeah. And the next question is for Dr. Parna Sharma. If there is an ultrasound finding such as a thick nuchal translucency or omphalocele, and this patient just refuses invasive testing for now, I said, I need some time to make up my mind. Does NIPT with appropriate counseling have a role here? Can an NIPT integrated biochemical screen first and second trimester, maternal torch titers and scans at 16, 19, 22 weeks match up at all to invasive testing in the perspective of a thick nuchal translucency?
So you're just getting all complicated questions to me. So here I would like to, have some points to, make some point-wise answers. Number one, when we say thick NT, we need to understand how thick is the thick NT.
Yes.
So that's number 1 point, because something which is between 95th to 99th centile has a good outcome in terms of 93% has a good outcome. So we should not just lose our minds over it. That is number one. And something which is, more than 3.5, even that has a 70% outcome, which is normal. So these are some of the numbers that we really, really need to remember. The number 2 point that we want to make here is that the causes of a thick NT goes much beyond aneuploidy. And that is something that we need to know. And at the end, this talk of NIPT and this panel of NIPT, if we remember that NIPT as of today is for 21, is for trisomy 21. So this is something that we need to remember. So if we are looking at thick NT, we need to rule out causes which are more than aneuploidies, which are structural anomalies, including congenital heart disease, non-heart disease anomalies, and also developmental and genetic syndromes. So what are we missing out if we just do NIPT is something that we should be bothered about. So that we're going to come. And the other thing is that there is something called a post-diagnostic evaluation for a thick NT. So that means, yes, our ultrasonologist and we have diagnosed a thick NT. So what is the evaluation that we are doing following thick NT, and is it adequate? So which should include a detailed anatomic survey, a fetal echo, like you have mentioned that we've done an echo, an infection screening, and also a genetic counseling. Now, if we have done all of this and all of this is negative and we have done NIPT only, then the risk of missing out a significant chromosomal abnormality is 2.5%. So this is something that we need to tell the patient. And believe me, it is all about the patient. So we just need to give them information, and we get all the spectrums of patient who says, I don't want to know the report, I will carry on this pregnancy. And there are some people who say, I don't want 1.001% of a risk and I will terminate this pregnancy. So it's all about offering information to them and letting them decide. So I feel, and also one very important stratification of this information is also that if the NT is between the 95th to 99th centile and you are offering NIPT, the residual risk reduces to less than 1%. So these are two very important, distinct features, that an NT which is more than the 99th centile, that is more than 3.5, and you are offering NIPT, the residual risk is much more, while the category in which the NIPT, the NT is between 95th to 99th centile and you are offering NIPT, the residual risk of chromosomal abnormality is 1%. Now we come to a final scenario where all of the tests you said are normal, you've done everything is normal. So what is the developmental delay? The pregnancy continues and what happens to the baby? So the prevalence of, in one of the biggest systematic reviews, they said that the developmental delay is 1.4%, which is actually normal, like a normal population. So definitely if everything else is normal and and all of the tests are normal, so maybe the outcomes are not very, very abnormal. So it is something that the patient and the couple have to decide, and we just have to present them the information. So increasingly studies are coming that, increased NT is not something that is very, very, cystic hygroma is something that is very different. That is definitely not increased NT, but increased NT has to be really dealt with in a balanced manner and not really, be very hyper about it.
Yeah. I'm so glad you made that so clear, because I think this was a very important take-home message today. Our last question for the faculty, and this is for Dr. Krishna Gopal. The Wuhan virus has changed the way we practice. Do patients now expect you, because they don't like to go to a hospital, for instance, or a crowded place, so do they now expect you to provide biochemistry, blood sample collection service in your ultrasound facility?
Yes, actually, patient has the cyclical behavior, particularly in Delhi. When the cases goes up, they have a certain behavior. When the cases goes down, they have a certain behavior. But still, because most of the obstetricians are doing video counseling rather than their regular OPDs, so the samples did increased, no doubt during. But at the same time, since this is the last question of our panel, so I want to put 2 points across and the take-home messages. One is what Dr. Ratna ma'am has told, that never put your screening test with other battery of the test. Give them a chance. They are different, and if you cannot counsel them. Counsel the patient about this screening test, sent to a fetal medicine center where they can be counseled, interpreted, and then both you and the patient will get the proper communication. Second is, never treat NIPT as a counter test like CBC and others. All the guidelines of the world suggest that pre-testing counseling is a must. So most of the patients that land for us for false positive NIPT, they always say that counseling has not been done. They are not aware about the false positive test possibility. So pre-counseling for the NIPT is a must, and don't advise this test without counseling.
Thank you. That brings us to the end of the questions for the faculty, and I'd like to now move on to look at the question box. I haven't had a chance to see it because I was busy, and we seem to be very popular tonight. We're still sitting at a score of almost 300 attendees, and I don't want to let them go away without their questions being answered. So let me start one by one. And we've already answered Dr. Uzma Sheikh's question. What is the medium put into the Streck tube? And I know Mr. Streck has certainly made more money than all the NIPT companies put together. And we still don't know what the formula is. It's like Coca-Cola, as we already know. Now, we also have from Dr. Uzma Sheikh to everyone a question which says, sir, kindly explain integrated screening and contingent screening as separate from each other. And one question, of course, we've already answered, which is when we add on the additional ultrasound markers, can we use them in low resource settings? So let's take this one question at a time. Bijoy, what is the difference between integrated screening and contingent screening?
Integrated screening is when you combine everything together. The first trimester screening you combine with your second trimester screening, and then you give an integrated result towards the end of the second trimester without disclosing the first trimester results. That would be a integrated form of screening, and that's not used nowadays because you have to have a second trimester test later on, and the first trimester screening result is not disclosed right away. A contingent model is when you divide the population into contingent groups, into 3 different groups based on various cutoffs. And that's exactly what we explained on how to use NIPT as a contingent model, where you have a combined test result and then you divide the population into 3 groups: a low risk group, a high risk group, an intermediate risk group. The low risk group goes home, they get no tests at all, but the high risk group gets an invasive test, and the intermediate risk group will either get like I mentioned, an NIPT, or what was done before was they used to have another test, like a quadruple test, which used to get integrated back with the first trimester combined test. So contingent basically means dividing them into 3 different groups based on your first line testing, whereas integrating is sort of a blinded procedure where you do a combined test initially and then add on the integrated test together and you get a final risk towards the end. Yeah. I hope that's clear. Yeah.
Perfect. And Dr. Parna Sharma, what would be the detection rate if we just added on additional ultrasound markers and we skipped the serum markers in a low resource setting? I mean, are we going to exploit the laboratory or are we going to exploit the radiologist, sonologist?
So if we add the ultrasound markers to the biochemistry?
No, we skip the biochemistry, and to maternal characteristics, we add on NT, but we also add on nasal bone and ductus venosus and tricuspid regurgitation.
Right, so I think that will be around 80%.
So, but the ideal thing is not to skip the biochemistry even in a low resource setting, because it doesn't really make up.
That doesn't really change.
Yes, and then knowing that the incidence of growth restriction and preeclampsia is so much higher, why not do a placental test as well? Because Down syndrome would be, say, 1 in 5 or 1,000 at birth, whereas growth restriction in some places is as high as 1 in 4 pregnancies. And we even have seen preeclampsia in some pockets of the country as high as 1 in 3 pregnancies, although they usually say that it would be an incidence of 3 to 8%. So we must have a placental test as far as possible. And a reinforcement of one of our messages from Dr. Kishore Rajurkar, who says that, of course, NIPT should not be offered like HPLC is offered. We don't offer HPLC to all patients with microcytic anemia. We must respect NIPT, and that's very well taken. We then have a question from Sarang Chobe, and she says, priming, low risk, non-consanguineous marriage, nasal bone hypoplastic at 19 weeks, no other abnormality. What is the next evaluation? This is for Dr. Ratnapuri. Isolated short nasal bone at the hypoplastic nasal bone at the 19-week scan.
It does have a high likelihood ratio and an isolated nasal bone, but we have to make sure that it is less than the 5th centile as per the charts. And I would also like to see what other tests have been done, what are the risk figures, what is that? Put it all in the correct perspective. And if at 19 weeks it still comes out to be a high risk, then offer amniocentesis, because we are still bound by the 20 weeks limit. And after counseling the families, I think I just wanted to say one thing. Let us not take for granted that the family wants to discontinue a pregnancy which is confirmed to have Down syndrome. They may not. So I think as doctors, we need to explain to them, and we don't talk of things like that they have mental retardation. Okay, word is not used anymore at all in science. It is developmental delay, and for children more than 5 years, it's intellectual disability. And I think it's very important that the couple decide what they want to do, because the baby is of the couple, it's not the doctor's baby. So I think that becomes very, very important, and a point we had not discussed.
Yes, thank you for that input. And then, of course, Dr. Hasmukh, who has helped me so much with the research on today's questions, reminding us that we must choose the right patient for the right test. And then we have a question from Dr. Nikita, which says, primary at 13 weeks. Combined test gives me a risk of 1 in 382. NIPT or invasive diagnostic test? Dr. Bijoy, could you please reinforce what you've told us?
Yeah, I've already mentioned this. The importance of NIPT is that it allows you to not do an invasive test, even in the high risk group, when you decrease your cutoff from 1 in 250 to 1 in 100. So this is definitely a low risk by any standards. If you use 1 in 250 as a cutoff, this would be a low risk mother who would have a trisomy 21. But since you want to increase your detection rate for Down syndrome, you can very well offer NIPT for this group. Invasive is not at all an option in this group, because the chance of having Down syndrome is going to be very, very less. And when your combined test is showing low risk, that is when its cutoff is above, when it's above 1 in 250, it means 99.99% there is no Down syndrome. The negative predictive value of that test is that high. So then if you still want to do an NIPT, then it's up to them. You can go ahead and do it. Yes.
Yeah, thank you. We've already answered Dr. Shrutik's question on NIPT vanishing twins. And then there's a question again from Dr. Kishore Rajurkar. He wants to know, do biochemical results of fetal fraction change with uncontrolled diabetes? Dr. Parna Sharma, please.
A quadruple marker is affected by definitely. So we need to mention the levels are affected by the diabetes. So we definitely need to mention the status of the pregnant mother, the mother's status, whether she is diabetic or not. So definitely fetal fraction, I'm not very sure about whether it is affected by diabetes or not, but definitely the biochemistry is affected by diabetes.
And Dr. Ratnapuri, what about the effect of uncontrolled diabetes on fetal fraction? That does not hold up. Yes. Thank you. We then have a question from Dr. Chandan Mohini. What is the role of quadruple test in second trimester in monochorionic and dichorionic twins? Dr. Parna Sharma, please.
So if you look at the NICE guidelines, they do recommend quadruple test in twin pregnancy, but none of the other society guidelines recommend a quadruple test. We do not do a quadruple test. So if you look at screening in twin pregnancy, we have very clear-cut guidelines that we should do a first trimester combined screening in twin pregnancy. Chorionicity does not affect the results of the screening test. Only the interpretation is affected, because in monochorionic, the risk is per pregnancy, and in dichorionic, the risk is per baby. That is the only difference. And we all should offer age, NT, and dual screening in a twin pregnancy. That is your standard recommendation for screening in twin pregnancies.
Excellent. Thank you. We then have a question from Dr. Devashmita Mandal, and she says that if a double marker first trimester evaluation has not been done in a pregnancy, should we replace, if she comes in later, at say 16, 17 weeks, should we just replace a quadruple test with NIPT? Dr. Ratnapuri, please.
I think it's a lot about costs, and it's a lot about seeing the pregnancy as a whole. So like very nicely, I thought Bijoy had put across, what are we dealing with? What is her baseline risk? What was her first trimester scan? I forget whether she said whether she's had any scans or something like that. Did she mention that? Has there been a first trimester scan, an NT-NB scan?
It has not been done.
It's been done.
Not been done.
Oh, so nothing's been done. So she's just landed up in the second trimester.
Yeah.
I think I would still do a quadruple screen and a good level 2 ultrasound. How many weeks is the pregnancy? Have we crossed that also? I'm sorry.
No, she hasn't mentioned the duration, but presuming it was say 17 weeks.
Okay. So I would do a quadruple screen. I would do a good level 2 ultrasound and take it on from that. I think we have to remember that everything in pregnancy is not about Down syndrome. The test still costs a lot of money. And I think we have to keep things in the correct perspective. Those are my thoughts on it. Of course, I would see the history. I would see, I would look at it as a whole and not just get after Down syndrome.
Yes. And then we have a question from Dr. Yashodhara Gaur on the fetal fraction value, which we've already discussed. And then again, a reiteration, Bijoy, Dr. Shashi Srivastava wants to know when the biochemistry, etc., put us into intermediate risk, NIPT or amniocentesis.
I've been repeating that the whole evening today.
It's all about repetition.
Yeah.
Why do you think we've done this today?
Okay, I'm just saying it once again. This group needs to be given NIPT. That's like the nth time I've been telling that.
Thank you. And we will remember that, and we will put this onto YouTube, and we will remember it forever.
That's good.
Wonderful. Dr. Uzma Sheikh wants to know from Dr. Ratnapuri, please explain the reason for PAPI and HCG affecting cell-free fetal DNA levels.
Because they're secreted from the placenta, and your cell-free fetal DNA is also coming from that. So that's the main reason.
Yes. And then we have a question from Dr. Deepak Kapoor on multiple pregnancy and the results of NIPT. We've already repeated that. And then a question from Dr. Seema Sultane. Nuchal edema seen at 9 to 11 weeks and disappeared at NT at 45 millimeters with a normal nuchal translucency. Dr. T.L. Praveen, what do I do now?
Well, once you have a nuchal edema at 9 to 11 weeks, positively you need to be strongly suspecting the possibility of a chromosomal or a structural abnormality. But once you have a nuchal translucency, which is normal at about 45 millimeters, that is the crown rump length, it is little unusual in the sense we definitely need to thoroughly evaluate the fetus for any structural abnormality, basically. And that is where I think instead of 45, in case if we can do it around 60 millimeters, then it would be ideal to really evaluate the structural abnormalities of the fetus.
Wonderful. Thank you for that. We have a question from Dr. Shilpi Jain. At 15 weeks, the nasal bone is unossified. The quadruple marker is normal. And how do we follow up this case? Dr. Aparna, please.
So I think the scan should be repeated and you do a level 2 normal genetic sonogram and we see what is the status at that point in time, and then we recalculate the risk and we see how things are. And then if it is falling under high risk, then we offer an invasive testing at that point in time or NIPT. That is the point where we decide.
Yes, so we do a serial evaluation and we give her the option. Some patients might actually go in for invasive testing at an earlier stage, and if she wants that, we can offer that. And we must keep on recalculating.
I would definitely want to recalculate the risk with a quadruple and a genetic sonogram, because that is what I would really recommend to do. And if it is in the high risk, then maybe because she's already 18 weeks at that point in time, go for an invasive testing.
And so we must become familiar with using calculators because they help us move faster.
And these are freely available on the net, so it is not
at no cost. Wonderful. Dr. Jaya Chawla wants to know, and this is a question for preeclampsia screening. What would be our evidence-based change in management besides surveillance in case our preeclampsia screening overall is low, but our PAP-A is less than 0.4 MOMs? Dr. Parna, please.
Sir, I think this has been given by the FIGO and the Poon article also. So this is what we generally follow, that, in second trimester also, we should do a uterine artery Doppler. We should follow with the blood pressure and the uterine artery Doppler. We see how things are and we recalculate the risk. Now we have risk calculator for first trimester, second trimester, third trimester. And if she's following in the high risk in the second or the third trimester, we increase the frequency of surveillance. See, aspirin has a role only before 16 weeks. After starting, starting aspirin after that doesn't really have much of a role. What really matters is now surveillance. And also now there are markers. So now if you feel that she is high risk, then of course there is increasingly, there will be a role of, prediction of preeclampsia later on with the markers like, SFLT and all, but it'll come. Now, right now, there is not of a practical utility because it is not commercially available very much, but soon we will have something. But right now, increased surveillance, if you find that something like, uterine artery PI, Dopplers, and follow up.
Yes, 2 weeks ago, actually, two very prominent companies have now made it very widely available and will provide us results within 4 days for PLGF as well as SFLT. And that's going to be really, really useful. Of course, not connected with our NIPT. Also not connected with NIPT, but a question of how can we decide in the 11 to 14 week scan to start aspirin. We'll leave that to one of our seminars on preeclampsia. This is from Dr. Yashodhara Gaur, and I requested to look at any one of our webinars on screening for preeclampsia. We then have a question from Dr. Shalini Agarwal and says, if the patient says, I don't want an amnio, do we terminate a patient with a positive NIPT? She missed her dual test NT scan. She had a scan at 14 weeks which showed bilateral small choroid plexus cysts, after which she decided to get NIPT done. And then a scan at 16 weeks showed nothing except a small echogenic intracardiac focus. So this is a series of follies that have been committed. And can we have the logic behind this kind of thinking? Because I know Dr. Shalini Agarwal, not the only patient who faces this. She's missed a first trimester scan. She's got a choroid plexus cyst. She chooses the wrong test for it and says, I want NIPT for this. We've heard that, yes, NIPT can tell us a bit, but it's not really the most, not the most sensible test. In 16 weeks, we have the EIF. So would everybody then agree that this was completely the wrong approach? And can somebody please tell me what should have been done? Dr. Bijoy, please.
I think this really difficult to correct something that's so messy, actually. Yeah. And so see, right now she's got an NIPT that's positive. If I'm correct, her NIPT test is positive. Is it positive or negative?
NIPT is positive.
NIPT is positive. So then I think what she needs to do is she has to do an invasive. There is no other way around it.
Yes.
It's positive. And you said she's a low risk.
She refused.
Yeah, so she needs an amniocentesis. So she needs an invasive test to confirm. There's no point doing a scan or whatever, because she's got if she's in the low risk group, she's got an 85% chance of having Down syndrome. If she's in the high risk age group, she's got a 95% chance of having Down syndrome. That's a really high risk for doing anything. There's no point doing any scan or anything. Just go for invasive. And if she doesn't want to do an invasive, and if she wants to terminate a pregnancy, God help her. There's nothing we can do.
Or whoever else is willing to help her.
Yeah.
And then we have a question from Dr. Chandan Moini. What test to order when we order the invasives? QFPCR, FISH, karyotype, CMA. Dr. Ratnapuri, please.
Depends upon the indication for what you're doing. If there is a malformation, it's better to order a microarray, and you would order a QFPCR. See, you have to understand the concept of a QFPCR and a FISH. They give you the same information. But I believe if you're taking out DNA, you have to do maternal cell contamination. You do a QFPCR. You're not splitting your sample into many things. For a FISH, you use the cells. You don't use DNA. Okay, so if you're doing a karyotype where you're culturing the cells, you're not taking out DNA, you do a FISH test. That's how I look at it. We know that if there is a malformation, this is well-established data, it's best to do a microarray. The reason for that is you get about 6 to 12% additional information beyond that of a karyotype. But if you're doing an invasive test, say just for a non-malformation indication, say a positive NIPT so for a positive NIPT, I think we are good with just doing a karyotype and a FISH, because you're looking at something which is very specific and targeted. At times when we order a FISH or a QF-PCR and an array, and if the QF gives an answer, you can cancel the array. This is not an era, the COVID era. People are really short of money. It's not the era to just flounder around money. And so that's it.
We have a question from Dr. Varnika Sa. Is the 1 in 100 cutoff in the first trimester screen valid for trisomy 21 only, or does this apply to 13 and 18 as well? Dr. Bijoy.
I was thinking you'll come with that question to me only.
Of course.
As far as 13 and 18 are concerned, already the cutoff is not 1 in 250, it is 1 in 100. And it is largely a scan diagnosis. I'm not worried about 13 and 18 coming out as positive. The cutoff is generally for 21. When you say 1 in 100, we're talking about 21. And if it is 13 and 18, already the screen positive rate is counted as when it is above 1 in 100. And we do a good scan. And if you find the markers, you definitely go in for direct invasive testing. There is no question of NIPT in trisomy 13 and 18.
Yes, we are racing against time, but we have some very short questions left. And may I request Dr. Asha Jain's permission to finish a few short questions. The first of these is to reiterate, does sensitivity of NIPT decrease with advancing gestational age of the mother? This is from Dr. Kamal Patil.
No, it doesn't.
Yes. And we could have a higher calls for donors, but not for no decrease in sensitivity. And Dr. Kishore Rajurkar wants to know about NIPT for rhesus, yes or no?
It's already been
already. And we move on to a question from Dr. Ashish Panchal. If patient is having combined test with intermediate risk and comes with NIPT as no call, what do I do now?
You will do exactly the same thing that we did when NIPT was not there. When NIPT was not there years ago, when this intermediate risk was not there, we used to tell them to go home and be happy. The same thing we will do if it becomes as NIPT no call, because we have a background risk done on the combined test, which tells us that her risk is extremely low. And the chance of having Down syndrome in that group is very, very low. So it's okay. The chances are very good that the mother will not have a baby with Down syndrome. But having said that, you can also always go in for not quadruple test, do a genetic sonogram and base your risk on the background risk of the combined test and just leave it at that.
Ultrasound is the first point in the protocol. Would that be quite justified?
Yes. Yes.
And then we have a question from Dr. Anupam Bhala. Thick NT at 10 weeks, but normal at 12 weeks. How to manage? And Dr. TL and Praveen has already answered that. And NT between 90th and 95th centile, does it call for anything extra to be done? That's also been answered. And once this is on YouTube, you can always handle this. And then a very interesting question from Dr. Kishore Rajurkar again. A patient of Down syndrome gets pregnant. Any difference in ordering NIPT? Dr. Ratnapuri, please.
So if you have a lady with Down syndrome, so men with Down syndrome are predominantly infertile. I don't think there's anything in literature would say that they become pregnant. But yes, women with Down syndrome can become pregnant. And I myself have managed 2 such women. They are at a very high risk of having a baby with Down syndrome. And I think it's I think that if we do NIPT, that's a bad idea because already she's got an extra chromosome 21. So I think there we would do an invasive test. NIPT is not a good option.
Thank you. We have a very interesting question from our COVID point of view. When should we do an amniocentesis if the patient has a recent history of COVID? Dr. Parna, please.
Yeah, so we do it when she becomes negative within 2 weeks.
Wonderful. And if she's negative today, can I do it tomorrow?
Yes, sir.
Wonderful. Do I need to repeat D-dimer, CRP, ABCD, EF, GH?
Nothing. She is negative. She's asymptomatic. I do it.
Yes. And then, of course, Dr. Rajkishore Bagri want to know why the NT becomes thick in trisomy 21. I'll skip that question today. We have plenty of references and webinars for that. Again, a question similar to what's been answered. This is from Dr. Sumita Sharma Mishra. If biochemical markers show increased risk for trisomy 18 and the scan is normal and the patient does not want invasive test, how do I counsel her? Dr. Ratnapuri, please.
I would leave her. So usually if you've done a good scan and it's trisomy 18 and the scan is absolutely normal, the probability that she's got trisomy 18 is extremely low. So if she doesn't want an invasive, that's her prerogative and that's okay. I wouldn't worry so much because I do know that she's going to have a normal baby. It may be confined placental mosaicism.
Wonderful, thank you. We have a quick question on how to calculate the middle cerebral artery peak systolic velocity in moms, not related to our webinar tonight, but of course we just read it off the charts. Then we have a question of an unossified isolated nasal bone at the 11 to 14 weeks window. And this is from Ashish Bhavatkar. How to proceed and counsel the patient. So, Dr. T.L. Praveen, so this patient comes and the only finding is an unossified nasal bone. What do I do?
Basically, I think we have to counsel them regarding the absence of the nasal bone, and at the same time tell them to calculate the risk factors associated with it, and probably take them over to the 15th week and the 16th week and then do an amnio in case if the risk persists and if you find that there is a possibility of a increased risk at that time.
Thank you. The next question is that maternal age, NT and B, just by themselves, the detection rate in perfect hands would of course be 90%. And of course we agree on that. Although we know that in ground reality, when we have people who are in a rush, people who are under pressure, people who don't have time or the expertise, it could be as little as 75%. Bijoy, would you agree that is ground reality?
Yeah, I guess, yes, true. You need to always combine with number of markers, but then your sensitivity increases. It is actually the sum of tests decreases your errors. It's always better to have a combination of things working for you. Yes.
Yes. And then of course we have Dr. Kishore Rajurkar reminding us that we all know that although a larger number of patients in India would terminate trisomy 21 pregnancies, some after screening may decide not to, and we should always keep an open mind. Thank you for that input. We have a question from Dr. Shweta N. And it says that knowing that PAPE is more sensitive at 10 weeks and that we do our scans at 12 weeks, should we just send in all our PAPEs if possible and the patient agrees to it at 10 weeks? Dr. Ratnapuri, please.
Sorry. So yes, the PAPE is more sensitive at 10 weeks, but remember there are multiple visits to the hospital. So typically that's why we take 12 weeks as a time period where we strike a good bargain. The patient comes in once, you do the NT, you do the free beta HCG and the PAPE and a combined first trimester screening.
And also the
if you have to do, and also if you have to do the preeclampsia screening, that's a good time to do the PIGF with your uterine artery pressures.
And then Dr. Tianfree, a question right there. Should we routinely use heart rate for assessing risk, which some of these calculations and demographics don't use?
No, but then the heart rate is basically to differentiate between trisomy 18 and 13. We definitely don't use a heart rate for differentiating between 21 and 18 or something. So I think, you can have a heart rate, but then I think the importance given to it is not much.
Yeah, thank you. And then there's a question from Dr. Kalpana Sivanesan. What would be the first line option when the first trimester combined screen comes as intermediate risk because of a hypoplastic nasal bone and all the other parameters were normal range, and a repeat scan at 18 weeks still shows a hypoplastic nasal bone, invasive or NIPT? We've already answered this question, that we took the whole thing into perspective and definitely consider invasive testing and not just leave it to good old NIPT to the extent possible. Dr. Ratnapuri, would you agree with that?
Yes, I would. It's 18 weeks already.
Yes. And Dr. Kishore Rajurkar wants to know about the possibility of NIPT for thalassemia in the near future.
The near future, I've been reading about it for many years. So right now it's not there. Yes. I think we'll just keep it like that. It does need invasive testing.
And then we have a patient at 37 years, third gravida, 2 living issues, perfectly healthy, combined screening, low risk, NIPT or amnio for a higher detection rate?
What?
It's low risk, sir. Why do anything now?
Very much. There is a question from Dr. Kusum Bera. If the second gestational sac persists without fetal cardiac activity till 15, 16 weeks, then how should we perform screening, Dr. Aparna?
Actually, literature has actually said that, these things can persist up to even 17 weeks after the sac has disappeared. So in these cases, just wait and watch. We really do not have to do NIPT if there is nothing else in the other baby. So just follow and do the ultrasound. Why insist on doing down screening unless you have some strong suspicion? And of course, if it's a DADC twin and the sac, you can see two sacs separating it. And if you have to do some testing, you can always go for an invasive testing. So you have some compelling reason to test, then you will always have an invasive testing to do. And there has to be a strong reason to do NIPT. So all of these things will create a confusion because there is evidence that, these cell-free DNA from the vanishing twin might even persist even up to 3 months. So we have to wait and watch.
And then a question from Dr. Shruti K about NIPT in heterotopics, like this with a cornwall pregnancy operated at 6 weeks. Any role of NIPT?
Tough to say, not much of evidence. I don't know. I mean, of course, there would
What
be
pregnancy?
Heterotopic pregnancy, ma'am, because one is outside, one is inside. So definitely there would be DNA, and heterotopic is a normal pregnancy. Heterotopic is just an ectopic pregnancy. So the baby which is inside till it is alive, normal. So I don't think that would really lead to an DNA. So anyways, heterotopic pregnancy, you would first manage the heterotopic pregnancy. NIPT would even not come to my mind. First manage the heterotopic pregnancy.
Yes, no, this is later on. She was operated at 6 weeks.
Oh, she's operated already.
Yeah, so if it is operated, so I'm sure it is after at least 15 weeks, you can go for NIPT.
So if she was non-surgically managed, which
even
means,
if it is non-surgically managed, sir, the fetus which was heterotopic would have vanished because of, at the most, I would put in a KCL in the heterotopic sac.
Correct.
So that would have vanished. So, give it 7-8 weeks. So give that amount of time. And if you really want to do NIPT, go after maybe 17, 18 weeks.
It was reduced at 6 weeks, and we wait another 8 weeks. Then after 14, 15 weeks, we were quite happy doing an NIPT. And then we have a question from Dr. Diptamoy Shahu, who wants to know how to approach a second gravida, one living issue, 29 years, with a previous Down syndrome boy, 7 years. And she comes to you at 15 weeks for the first time. Dr. Ratnapuri, please.
So we know that 95% of children with Down syndrome is a free trisomy 21. So in this situation, the recurrence risk is 1%. Now, in my experience, the patients don't even want that 0.2% or 0.3%, whatever is left of an NIPT. And I think I respect that because it's not easy to bring up 2 handicapped children. So you explain them both, and majority of them go for an invasive test. But if they don't want to go for an invasive test, and I know that the karyotype of the first child is trisomy 21, it's fine to do the NIPT also with a good scan, with a good 18 to 20 week scan. However, a small percentage, 4%, have a translocation Down syndrome. In that case, you need to karyotype the parents. Remember, in that, there's another chromosome involved. And if that is a situation, then it would require an invasive test. And we have one situation of a inherited 21-21 Down syndrome. That means one parent is a 21-21 translocation carrier, and the child has a 21-21 Down syndrome, a translocation Down syndrome, which is involving 3 21s, where 2 21s are piggybacked on each other. And these, in this situation, there is never any chance of giving birth to a normal child. Because remember that 21-21 will always come from one parent, and the other parent will give a 21. So here you have to talk about either an egg donation or a sperm donation, etc. So it's uncommon, but it's important to check that before you offer NIPT and things like that.
And then retracting a bit from NIPT, Dr. Kavita Aneja wants to know the value of a first trimester quadruple or a first trimester pentamarker Any preferences? What's the evidence? Should we move on to these more so-called better screening tests? The intermediate levels between our combined screen versus an NIPT. What is your opinion? Dr. Parna?
Actually, these are all research mode. And currently the biochemistry you have to understand why these things came is in a situations where we do not have good NTs. So the studies which are there, they are trying to validate that if you do not have an ultrasound, so if you add alpha fetoprotein or if you add inhibin, so that you would be able to achieve a detection rate which is equivalent to quadruple second trimester, only by doing a biochemistry. So that is the logic of adding alpha fetoprotein or adding inhibin. So it is not like you are adding or gaining something by doing already a combined screening, which is having ultrasound plus dual marker. So if you add NT plus dual marker plus alpha fetoprotein plus inhibin, you're not going to gain too much. But this is a futuristic thinking, or in settings where you do not have a good radiologist, where you cannot offer a good NT. So if you do, that is also a thinking, a kind of a module and a thinking which needs to be more worked up, or more research is supposed to be done on it, if that could be a workable module. So that is not something that is, too much to think about.
Thank you for that. And we're now not going to answer our question that came in after 10 p.m., please, because you really answered every single one with lots of love and care and detail until that much time, except for one last question, which said that we had an NIPT which was high risk, and the fish showed a mosaic Downs, and the karyotype was normal, but the patient had already opted for a termination of pregnancy after the fish. Dr. Ratnapudi, what is your opinion on this?
I would want to know what percentage of mosaicism was present on the fish, and why was it not picked up on the karyotype?
Yes.
It's a little unusual.
So we really need to investigate this in detail, and there are no straightforward answers to this situation. We need to sit down with this information. Wonderful. Dr. Krishna Gopal, you live in a part of Delhi which is very unlike the older part of Delhi, even though you handle 3/5 of Delhi's population. Do patients come dictate to you that they want an NIPT? May I have an NIPT, please?
No, sir. Actually, it is other way around. When we do counsel them, the first question they ask, sir, from which test we will get the answer between yes or no. So when I tell them that it is a screening test with chances of false positive reports and the chances of false negatives as well, though they are scanty, negligible. So they mostly opt for invasive testing. Sometimes we have to tell them specifically that in your case, I think that the NIPT is a better option.
So we must really put them into a cafeteria approach then, irrespective of what their demands are.
Yeah.
I noticed that Dr. Bimal Sani is still with us after the last few.
Can I just answer that? Dr. Praveen wrote back that on fish, the mosaicism was 3%. I only wanted to say that when we do fish, there's always some mosaicism. My lab has a cutoff of 5%. So I think that fish was normal. It's got to do with primer binding, probe binding, hybridization. So I would not take 3% as a mosaic Downs. Thank you.
My last answer, because I really want this input from Dr. Bimal Sani, who works in this town of Aurangabad, which is regarded as extremely civilized, but has a very heterogeneous population. Dr. Bimal Sani, what is the uptake of NIPT amongst your patients? Bimal, can you hear me? You'll have to unmute yourself. Oh, they haven't put you in.
And the link, probably.
Yeah. Now I'm unmuted.
Yeah.
So in our area, NIPT is something which has come very, very recently. So we are actually using it more as a part of the contingent approach that Vijay has talked about. Because for all practical purposes, I feel this pre-test counseling is a concept which actually is available only in webinars and panel discussions. In real life scenario, this does not take place at all. And in spite of all efforts that, I may also come and say all this, but even as an imaging person or a fetal medicine center, when the patients come, a lot of times the counseling which you do is usually post after the NT scan has been done. And that is the time you try to explain all this. So this pre-test counseling stuff does not really happen. And one more point which I really wanted to make was that, we all say that, okay, 1 in 200, we need to offer NIPT. So when we say we need to offer NIPT, in the sense, we are actually not telling them that, yes, because at the same time, we are also telling them the limitations of NIPT. And then we are also saying that, yes, what is going to be more accurate is going to be an amniocentesis. So eventually, a lot of times, when you tell them that, yes, it still has its own limitations, the option of an amnio in many a times is more acceptable to the parents, because finally when you have told them that yes, there is a risk and this is going to be a more accurate test, that is what people would actually opt for on a general that we have seen here, because eventually the cost factor comes here and the cost eventually for both of them comes to the same thing. But yes, I think, yes, not as a primary screening test. Maybe that's happening in the metros. NIPT is becoming more of a primary screening test. But I think the conclusion which has come from the panel today is that, yes, I think none of the panelists have really advocated the use of NIPT as a primary screening test. And I think I'm really happy the message has really gone throughout the nation that, yes, I don't think we are still ready to use NIPT as a primary screening test, because it's just about downs and we're going to miss a lot of things. So a wonderful, one of the best webinars we've had, one of the best panel discussions we've had, with a lot of clarity on so many things.
Thank you so much. And with that, I'd really like to thank my panel. We've had the most brilliant answers ever. We've really come down to ground level, made sure that we first introduced the most exciting answers, and then the questions reinforced what we had already said. And thank you, my panelists, for having the patience to repeat the same message again and again. And my apologies for our friends from imaging to not give them so much of this, but the point is that we really have to drive the point home that although Krishna and Dr. TL and Praveen and me always get stuck with as much of the pre-test counseling, we try our best to do a good job, but it would be so nice if the clinicians could take time off or just refer to a center and say, okay, please pre-test counsel and then go ahead. Thank you so much for being here tonight. And over now to our host, the Raipur Obs and Gynae Society, and Dr. Tabassum for her vote of thanks.
Good evening, everyone. On behalf of Society of Fetal Medicine and Raipur Obstetrics and Gynecological Society, I thank you everyone on the 7th episode of Excellence. I would like to extend my gratitude and thanks to Dr. Ashok Khurana sir for today's unique MCQ style session on NIPT. I'm sure all our delegates got the answers of why, when, and what next today. Thank you, experts, Dr. Ratnapuri ma'am, for throwing light on especially fetal fractions and positive predictive values of NIPT conditions other than 13, 18, and 21. I would also like to thank Dr. TL and Praveen sir, especially for opening the windows of counseling, combined counseling from obstetricians as well as the sonologist. I would also like to thank Dr. Krishna Gopal sir for all the practical tips given today on NIPT. I would like to thank Dr. Aparna Sharma madam, especially for showing us the importance of evaluation of 11 to 14 weeks time frame, and also giving evolving evidences, especially on vanishing twins. My special thanks to Dr. Bijay Balkrishnan sir for his inputs on newer cutoffs which were given today, and newer insights, especially on ovum donation and all. My sincere thanks to all the experts for providing fresh insights on the topic today. I would like to thank Dr. Bimal Sihani sir for his inputs. My sincere thanks to our president of Raipur Obs Gynec Society, Dr. Asha Jain madam, and all the delegates for the interesting and excellent questions. My sincere thanks to our trade partners, GE and LifeCell. So thank you, everyone. Thanks one and all, and good night.
Thank you. Thank you very much. Good night.
Thank you.
Thank
Good night.
you.
Thank you.